Network Mount Sinai Hospital in Toronto, Canada. Thank you.
Thank you, Dr. Mayo, and thank you, everyone, this morning. It's a great opportunity to be here and participate in this very nice session. It's nice to see the diaphragm getting front and center attention at this important meeting, so I'm happy to be here. These are my disclosures related to this talk. So I think you probably already had, I'm sorry I arrived late because I was at another session, but you probably had some introduction already to the diaphragm. As you know, it's this dome-shaped muscle composed of the crural portion that attaches into the lumbar spine and the costal portion that attaches to the inside of the chest wall. And much of the diaphragm is actually directly abuts against the chest wall in what's called the zone of apposition. And when the diaphragm contracts, it moves much like a piston inside a cylinder. I think sometimes it's perceived to be this sort of, it's a bowl that gets shallower whenever it contracts, but in fact it's more like a piston moving within a cylinder. And as a consequence of that, we can visualize the motion of the diaphragm in two different ways. First of all, we can look at the motion upwards and downwards, or the excursion of the dome of the muscle. And secondly, as the muscle shortens in the zone of apposition, you can see here that during contraction it progressively shortens in the zone of apposition. As a consequence of that shortening, the muscle thickens, just like any muscle thickens when it contracts. And this thickening is directly related to the degree of shortening of the muscle. And so we can visualize both excursion and thickening by ultrasound, which, although it's not a gold standard technique like frank nerve twitch, gives us, I think, a very useful way of feasibly assessing the diaphragm in the ICU. So this is what it's like to image the thickness of the diaphragm. You use a linear array probe positioned over the right hemithorax, usually in the 9th or 10th intercostal space between the anterior, or just behind the anterior axillary line. And this gives you this B-mode image here, which lets you see the diaphragm in cross-section. So the bright echogenic line here is actually the peritoneum, and then the bright echogenic line here is the reflection of the parietal pleura in the zone of apposition. And so you can measure the thickness of the muscle with this imaging technique. But it's not just the thickness at end expiration that we're interested in, it's the actual thickening of the muscle. And so here I've outlined the diaphragm with these blue dots, but if you watch the diaphragm with ultrasound, you can see that as the subject inspires and activates the muscle actually thickens. And you can quantify this thickening in M mode, which produces an image like this here, and we quantify the thickening fraction as the percentage increase in thickness during inspiration, which is the percentage change from A to B and from C to D. And using this technique, we've been able to show that you can get, in mechanically ventilated patients, you can get reasonably reproducible estimates of the activity of the diaphragm and of its function. The other technique is imaging of excursion. And here a phased array transducer is placed in such a way, usually just below the costal margin, that you can visualize the dome of the diaphragm. And unfortunately the tracing here is cut off, but if you place an M-mode line over the dome, as the dome moves up and down, you get a tracing that looks very much like the tracing of a transdiaphragmatic pressure curve, which I'm sure you already saw from Leo's talk. So the message that I've been asked to convey is that ultrasound is useful, directly addressing the question that was raised just a few minutes ago. So there's a whole range of uses of diaphragm ultrasound. Now when I looked at the program, I saw that immediately afterwards someone was going to be presenting on the clinical uses of the technique. So I've decided to focus mainly on some of the research insights that we've been able to derive with the use of the technique and the potential application that it might have for guiding mechanical ventilation. So we did this study in mechanically ventilated patients that Dr. Dress already referred to. We enrolled patients within 36 hours of intubation and followed them making measurements of diaphragm thickness and thickening fraction on a daily basis for up to 2 weeks. And and then followed them to look at clinical outcomes and a number of physiological endpoints. And we refer to our findings as, we like the term myotrauma. So the impact of mechanical ventilation on the diaphragm has long been referred to as ventilator-induced diaphragm dysfunction, which is an important and clear term, but just an analogous to ventilator-induced lung injury. And similarly, by analogy, just like we have volutrauma, atelectrauma, barotrauma, we also, I think, could propose the term myotrauma as a way of referring to these mechanisms of diaphragm injury related to mechanical ventilation that lead to VIDD. And so that's what I mean by this term myotrauma that you'll be seeing me put up on the slides here. So the first thing that we found was that, as expected, close to 50% of patients had no change in diaphragm thickness over time, and another approximately 40% of patients had this rapid early decrease in thickness. And to our surprise, as Dr. Dress mentioned, there was this smaller group that had a rapid early increase in thickness. And what was interesting is that both the patients with a decrease in thickness over time and the rapid early increase in thickness had lower maximal thickening fraction, which we use as a measure of function. So when you measure the thickening of the muscle, you can measure the inspiratory thickening when the patients doing their usual tidal breathing, and in that way the thickening reflects the patient's inspiratory effort level. But when you have the patient make a maximal inspiratory effort, just as you would during a measurement of a maximal inspiratory pressure, that maximal thickening becomes a way of assessing the function of the muscle. And so you can see here that the patients with both decreased and increased thickness over time had relatively lower maximal thickening, although the signal was only significant for this side because there were relatively fewer patients with an increase in thickness who had the measurement. So this is not a significant effect, I should point out. In terms of the impact and outcome, Dr. Dress already showed you this figure. What we're looking at here is a model where we relate the relative daily hazard of liberation from mechanical ventilation to the change in thickness over time. And let me just explain the analysis here. This is a complicated issue to study because obviously developing changes in thickness of the diaphragm takes time. So you're on the ventilator for some period of time. But clearly, the longer you're on the ventilator, the more likely you are also to be at risk of prolonged mechanical ventilation. So there's important what's called time-dependent confounding. So in order to address the time-dependent confounding, we used this complicated survival model that takes into account this issue. And so what this basically plots is that on any given day, the hazard of liberation from mechanical ventilation is lower, which is a bad thing, the more different your diaphragm is from what it was on baseline. That's what this plot shows. So hazards are a relatively abstract conception. What does that actually kind of more concretely mean for the patient outcome? Well, this is a different way of plotting the same result where it's called a cumulative incidence curve. So on the x-axis we have time with the duration of follow-up. On the y-axis we have the cumulative incidence of liberation or death. And your time on the ventilator ends either when you die or when you're liberated. So we split the two groups to address this competing effects. And so these curves here specifically reflect the patients who are being liberated from the ventilator. And you can see that compared to the patients with no change in thickness, that is the patients, the black line here, the patients with early decrease or increase in thickness had a significantly slower incidence of liberation, so that by the time you reach day 21, which is sort of our conventional accepted definition of chronic critical illness, your risk of remaining on the ventilator at that point is approximately double based on changes in the diaphragm that we're seeing in the first 3 to 4 days of mechanical ventilation. So this phenomenon seems to have a really profoundly important impact on patients. And similarly, the length of stay in the ICU is related to the change in thickness over time. Both patients with a decrease in thickness and patients with the early increase in thickness had prolonged risk of ICU stay and also risk of complications such as reintubation, tracheostomy, or prolonged ventilation. And the importance of this is, I think this is a key outcome, because there's a lot of data now that suggests that the longer you're in the ICU, the higher your risk is for long-term functional disability after critical illness. So this suggests that these changes in the diaphragm that are occurring in the first several days of ventilation might have a significant impact on a patient's long-term functional status by prolonging their risk of prolonging their time on the ventilator and predisposing them to all the nosocomial complications that come with that. So we might actually be able to use ultrasound, though, to try and prevent this phenomenon from occurring. One of the striking things that we observed with ultrasound was that the rate of change in the thickness of the muscle was directly related to the level of activation of the muscle measured by the thickening fraction. So here, this plot here is a little complicated, but I can easily explain it. So the y-axis here, or the z-axis, sorry, is the percentage change in thickness. The x-axis is the duration of ventilation, so you're looking at changes over time. But you can see that the direction of change was related to the level of activation of the muscle measured by the thickening fraction. So at very low levels of activity, i.e. Diaphragmatic quiescence, you see this rapid atrophy as predicted. And then the rapid increases in thickness at very high levels of activation, which are what make us concerned that this is the kind of load-induced injury that we're observing. But patients who had an intermediate level of activation, a thickening fraction in the range of 20 to 40%, had relatively stable thickness over time. And so this suggests that maybe we should be titrating ventilation in order to achieve this range of inspiratory effort, whether you're measuring it by ultrasound or by other techniques, in order to avoid diaphragm injury and promote a better outcome. And based on this, we hypothesized that the duration of ventilation should be related to the average level of inspiratory effort. So if your effort levels are very low or very high, you should have a longer time on the ventilator than if you have an intermediate level of effort. That is a U-shaped curve. And when we looked at the data, that's exactly what we found. This remarkable U-shaped relationship between the average level of inspiratory effort measured by the thickening fraction over the first 3 days of ventilation and the duration of mechanical ventilation. And so possibly this target window here in the range of 20 to 30%, which is similar to what you would see healthy subjects breathing at rest, might be the target for a diaphragm protective ventilation strategy. And it was Leo Hunk's very nice editorial in the Blue Journal that coined that term, diaphragm protective ventilation, that hopefully we'll be increasingly using in our clinical parlance. So I want to thank you for your attention and put in a shameless plug for our mechanical ventilation course in Toronto in June, where we will be discussing the diaphragm in all its glorious detail. And hopefully you can join us for a very exciting 3 days.